All right, so the areas that are highlighted by the arrows represent the same plastic or same non-neoplastic. So every one of those and all the other ones that are not, that don't have an arrow beside it, whatever looks very, very abnormal, it's the same non-neoplastic. It's not some kind of process, it's not some type of cortical reaction. These are benign neoplasms, right? Obviously, they are radiopacities. Yes? Obviously, this is a radiolucency, pretty much unilocular. It does have a somewhat regular board interior, but it's very low profile. Yes? Yes.
For question one, is that a multi-ocular?
No.
No.
Seem to stump a few people. Okay, so we look at the entire image from top to bottom, left to right. You see ultraviolet radiopacities in the bone, yes? Sclerotic. This process is most likely the result of what? What's that? Two. Speak up. Doing what? Right, and it's encroaching, definitely encroaching the pulp tissue, and it's causing this inflammatory process. Does everyone see that? So it's not a neoplasm, and it's not a metabolic process. Any questions? So based on this spatial orientation of the radiolucency, what disease category does it most likely belong to? What's your answer? Donogenic. Why is that?
It involves an uninterrupted too.
Because what?
It's associated with uninterrupted too.
It's associated with the crown of an impacted tooth. Not the roots, not the bone, or surrounding teeth, because it's associated with the crown of an impacted tooth. That's the biggest clue, or at least make you consider this odontogenic. Any questions? All right. So the appearance of the lesion highlighted by the red is best described as what?
Radiolucency.
Multilocular radiolucency, not ground glass. But I think for the most part, well, it's not mixed radiolucent or opaque. This is multilocular. Yes? so first, maybe just two non-odontogenic pathologies that can look like this radiograph. Potential giant cell granuloma, aneurysmal bone cyst,
Multiple myeloma.
multiple myeloma? No. Non-odontogenic. What's that? Sure, yes. All right. Give me four odontogenic pathologies that can give off a multilocular radius. Myeloblastoma. Odontogenic lymphoma. And these are the, go ahead. OKC. Odontogenic. What's that? You said what? Calcifying epithelial odontogenic tumor? N4 tumor? Yes. Anything else? So these are the things I'm expecting you guys to be able to run off the dome. Please be able to categorize non-odontogenic and odontogenic. If you mix them up, that's going to be a problem.
I think I got stuck on the non-odontogenic, went straight to that category from the part one.
You went straight into that.
The one with the, like, nasal palate, the one in that category that was non-odontogenic. And I think I got stuck in that, didn't even consider going outside of the things we were getting. I know that was one problem.
Like the non-odontogenic.
Yeah.
That's fine. Still got time. Any other questions? Any other testimonies? Yes.
Why would contiguous not be considered correct answer? Because, like, it's not common, but it can.
There you go.
Sorry.
There you go. It's not common. What did you put? Do you remember what you put?
I don't put contiguous because.
No, I mean, what else did you put?
The oculoid odontogenic cells.
So you were able to find a variant of lateral periodontal cyst called the oculoid odontogenic cyst, which I give you credit for, and kudos to you. Go on. What else did you put?
I didn't put that was like, that was another answer that I thought of after I.
Someone did.
I was just thinking that, like, so I said that it can be hard to differentiate between lateral periodontal cyst and contiguous cyst. In contiguous cyst, it could have a multilocular radiolucency if it's large. And I was just assuming the question was that, like, what it can.
Because I think if I'm correct, I don't think you put odontogenic lymphoma. Someone who put contiguous cyst did not put odontogenic lymphoma. And in my mind, I'm trying to figure out why would you put a contiguous cyst that rarely can show this way. Why would you put that before or above an odontogenic lymphoma? Right. But the questions, or at least the answers that I got, a lot of them did not put myxoma. They put contiguous cyst. And that's just an exceptional case. Even with macho, contiguous cyst is not part of that pneumonia. Right? Any other questions? All right, so I got two more non-odontogenic primary bone diseases that I want to go over, and that'll be it. So just added to last week's intraosseous hemangioma or intraosseous arterial venous malformation. Give me a second. It's not, it's cannabis. Probably Tuesday, but come see me at my house. Okay, plasma cell neoplasms. Essentially, they can be broken up by clinical pathologic variants. There's the solitary plasmacytoma of bone, solitary extramedullary plasmacytoma, and the big one which we'll focus today on multiple myeloma. Basically, we're looking at a malignant clonal expansion of malignant plasma cells. Does everyone remember from general pathology the function of plasma cells? What do they produce? So plasma cells are part of the immune system, right? So do you remember what they produce? What's that? Actually, they are derived from B cells, but the plasma cells specifically produce what? Antibodies or immunoglobulins. And that's very important because these malignant cells produce non-functional, excessive amounts of immunoglobulins. So with multiple myeloma, again, it's typically a malignancy of the elderly, rarely diagnosed before the age of 40. There's a strong female predilection, and they may present as a solitary lesion, hence the term solitary plasmacytoma bone. But those lesions typically progress to multiple myeloma. So they can either present that way, or they can present just as one or more commonly, or one of multiple bone lesions. Yes. No.
It's like a developmental anomaly.
I'll promise I'll get through troublesome campus and have it for you. I hope. I've been having submission from campus these last couple of days. Just know with multiple myeloma, bone pain is the most characteristic symptom. Obviously, patients can present with lip chin numbness, pathologic fractures, a type of anemia. Probably, I think you should be well familiar with. It's myelophasic anemia, and myelophasic is just a crowding out phenomenon that occurs in the bone marrow. So you have these malignant cells that crowd out all of the normal functioning cells that you have in the bone marrow, erythrocytes, platelets, white blood cells. And as a result, a lot of these patients are going to suffer from fatigue because this sort of crowding out or replacement of erythrocytes occur. They're going to have an increased chance of infection because the white blood cells are being replaced, and thrombocytopenia, the platelets are being replaced. Intraorally, you can see these sort of pinpoint hemorrhagic foci called petechiae. What's interesting about the multiple myeloma bone lesions is that they can also cause what's called metastatic calcifications. Soft tissues become infused with calcium because the tumor pretty much destroys the bone, goes through this sort of osteolytic process, and it frees up excess calcium. Also, because of these immunoglobulins, these sort of excessive circulating immunoglobulins, you can have a combination of light chains or heavy chains, and light chains and heavy chains are just the components of immunoglobulins. So you have all of that circulating within the serum, and eventually they can spill into the urine. They can cause renal failure. And these patients, typically, at least 30 to 50% of them will have what's called Bence-Jones protein in their urine. And basically, Bence-Jones protein is, again, just high count of light chain portions of the immunoglobulins. 10 to 15%. Again, the light chain proteins, they can sort of make their way into soft tissues. Some of the more common sites extraorally is the periorbital skin, where they can form these sort of firm, waxy deposits of amyloid. Okay, and intraorally, they typically affect the tongue. Usually the lesions are nodular, or they can just cause diffuse enlargement of the tongue. But again, in many instances, this may be the first sign of multiple myeloma.
This is similar to the amyloid material that you can see in the calcifying.
Yes. Somewhat similar, yes. So when we look at the bone lesions, again, with multiple myeloma, they are what's called punched out radiolucencies. They can be very well defined or ill defined. The skull film in many of these patients will present this way, where you have multiple, numerous, discrete, punched out lesions involving the calvarium. In the jaws, again, these punched out lesions can be seen focally or in a more symmetrical, generalized distribution. Keep in mind that each one of these radiolucencies contains this sort of proliferation of plasma cells. So when they're biopsy, this is exactly what we see. Diagnosis, lab results when it comes to multiple myeloma in the serum, in urine, when they're placed under protein immunoelectrophoresis, there's what's called a M spike or M protein spike. And that just pretty much means that there's a monoclonal gammopathy. Monoclonal gammopathy just means that there's an overproduction of a particular immunoglobulin or a fraction or a portion of an immunoglobulin. And that's just kind of seen or at least depicted by the red spike or the red waving here. So again, with multiple myeloma, historically, these patients have very, very extremely poor prognosis. 10%, usually survive after 5 years. The treatment goals essentially is to control the malignancy, provide some palliative support, and to increase survival by all means. Currently, there are many chemotherapeutic agents that are available, and they've even been able to identify cytogenetic profiles for these lesions. Depending on the profile, depending on the types of genetic and molecular changes, that will determine the overall outcome. So comparatively, currently these patients do survive a lot longer, anywhere from 2 to 7 years. But again, historically, this was almost a death sentence. All right, Langerhans cell disease used to be termed histiocytosis X, and basically it's just a collection of clinical pathologic disorders, and it's characterized by, again, another proliferation or monoclonal expansion of histiocyte-like cells called Langerhans cells. Believe it or not, there is a histiocyte society. They pretty much updated the classification system, and for the most part, when it comes to prognostic categories, your low-risk patients will have involvement of the skin, bone, lymph nodes, and pituitary gland. High-risk individuals will have lung, liver, spleen, and/or bone marrow involvement. Again, this is just a proliferation of Langerhans cells. The really sort of granular red cells, those are eosinophils. Eosinophils, for some reason, love to proliferate along with Langerhans cells. These sort of pale staining cells that you see amongst the eosinophils, these pale staining cells are your Langerhans cells. And again, Langerhans cells are dendritic. They're antigen-presenting cells. They typically function to present antigens to T cells, which then lead to more specific immunity. So again, with most of these proliferations, especially monoclonal, this particular disease is known for its BRAF mutation. So again, clinically, with Langerhans cell disease, yeah, there's a whole, patients over a wide age range are affected, but greater than 50% of your patients are going to be under the age of 15. Sex predilection is unclear. It can present as a solitary or multiple lesions, and less than 10 years of age. These patients usually have skull and femoral lesions. Again, jaw lesions can be either solitary or multiple. And in fact, you'll see these probably 10 to 20% of all cases. And these patients will present with dull pain and tenderness. Now, with Langerhans cell disease, just like multiple myeloma, one of the radiographic patterns is sort of the punched out radiolucencies, but they also can present as what looks to be severe generalized periodontitis, and even the bony defects, the sort of tooth, the bony defects have been historically characterized as teeth floating in air. I will say that I went over a national board exam, and actually they asked a question about punched out radiolucencies, which I thought was kind of interesting, because usually with Langerhans cell disease, it's always been associated with this teeth floating in air kind of pattern. But interestingly, they did have punched out radiolucencies, so just be aware of that. Yes.
So, like, looking at this, nothing, it doesn't really, it looks like large radiolucencies to me. Oh, okay.
And this sort of scooped out pattern. This is sort of the representative of severe periodontal disease. And you guys can kind of see the floating in air kind of. So this is at least classically, even when I was a student way back in the day, that was the first thing, the only thing they gave us. But quite interestingly, this is very, very similar to multiple myeloma.
Question.
Uh-huh.
So like wormian bones? Are
Yes.
those more like plate kind of looking?
So Wormian bones would be associated with what disease? Anyone else? What's that? One more time.
Osteogenesis imperfecta.
Okay. So your question about Wormian bone?
Like, what do they look like? Like, they look different than these?
Absolutely, much different. They have more of a wavy, irregular, sort of, presentation. They're almost, you'll find them around the suture lines of the skull. And if you can see right here, this sort of squiggly radiolucency right at the skull base, that's where you're gonna find your Wormian bone.
So that punched out was
You could see punch out lesions affecting the jaw. You can see just about, yeah, you can see punched out lesions affecting the jaw. These, the floating or the other severe defects, like you would see in the mandible, you probably won't see in the skull. Yes,
If you see the punched out lesion, radiolucency in the jaw, they kind of like onions in front.
just punched out. Usually with a punched out pattern, the lesion is so aggressive that it's literally eating through the bone and it doesn't give the host enough time to react to it. In the case of a periosteal reaction, when you have this duplication, onion skinning, that's just one periosteal reaction, but it doesn't happen here. This is a very, very, along with multiple myeloma, very, very aggressive malignancy. Okay, any other questions? So again, just add these two, along with the intraoral, intraosseous vascular malformation lecture to your non-odontogenic disease list. Okay, basically, if it's up to you, or if it's okay with you, we can do an actual review virtually, or we can do it in person next week. That's totally up to you, but today I just want to leave you with a few facts about the final exam. So it's 100 questions for 2 hours. Okay, it's cumulative, and I need you guys to really understand radiographic features of these entities. In addition to the other stuff, clinical features, definitions, but because there's going to be a sizable number of questions where I'll ask you to either identify or give me the most likely differential. Because again, just think, when you're in the clinic and it's just you, the patient, and that radiographic image, you're going to be, you have to be able to code switch from the pictorial to the literal to the layman. So the layman, as far as breaking it down to your patients so they can understand what you're saying, and you analyzing and reading images. That goes for clinical, or at least intraoral, extraoral lesions as well. So just know that there's gonna be quite a bit of radiographic related questions. Yes,
For those questions, do we have like multiple images, or would you just, like, say for this example of this, would you just put the lower right, or would you give us two to kind of, since if we're in the clinic, we're gonna have those images?
maybe,
Ideally, do that. I'm just talking about our exam.
you may. You may. All right, so 2 hours, questions. There's no remedial for final exams. So please study hard, study long, study together. Yes,
Will there be any like emphasis on the second half of the semester versus like what we were already tested on in the midterm?
it's all cumulative. Yes, one more time. Yes. That's why I gave it. Yes.
Main characteristics, or will it be like emphasis on like decades pretty much?
Oh, you mean like demographics, age?
Yeah.
Predilection.
More of an emphasis on like.
There'll be more of an emphasis on clinical presentation, radiographic presentation, some treatment and prognosis, especially the ones that have a real significant prognosis. Or places the patient had a high risk for something. Like if you see multiple radiopacities, this patient's gonna be at risk for what? And if those radiopacities are osteomas, what are they at risk for? What about Barton? What are they at risk for? What about polyps? What about the intestinal polyps?
Colon cancer.
Colon cancer. Colon cancer. Yes? Remember that? Something like that. Any questions? Yes. Oh, sorry, hold on. Oh, yes. Everything. So again, this liaison, Miller, put it to a vote to see if they want virtual or in-person.
Virtual.
What's that?
Virtual.
Virtual. Okay. Yeah.
That's why I was on virtual.
So you have, okay.
Friday